very big topic containing various types of shock. Do you know any types of shock? The common one which we have learned with adrenaline is anaphylactic shock. What else? Cardiogenic shock. Yes. Then hypovolemic shock. Yes, very good. Then septic shock. All these things are there. So what is this shock? Why there is circulatory failure? Even though there is adequate amount of blood, maybe in case of septic shock, in case of obstructive shock, there are all other terms. What we call them as distributive type of shock, other than the regular anaphylactic shock. Okay. So shock is derived from the French word push. It was believed that it has arose due to some failure. Okay, here are some other altered form of cerebral function, and here there is inadequate delivery of oxygen to the tissues. Okay, this urge to get enough amount of nutrition from the peripheral tissues will raise this shock. Okay, this will result in global tissue hypoperfusion and metabolic acidosis. So what it can trigger? So shock can occur with normal blood pressure and hypertension, and can occur, this hypertension can occur without shock also. For example, on the OPDs you can see many people coming to you with low blood pressure as much as 70, 90, all these things. Okay, but the patient may not be shocked. Okay, these two terms can be isolated. Shock can occur at normal blood pressure, and hypertension can occur without shock. Okay. Next, what this hypoperfusion or the decreased oxygen delivery can trigger? This can first trigger the sympathetic system. Okay. What is the sympathetic system activation do? So, release of this catecholamines. Okay, epinephrine, norepinephrine, and dopamine, cortisol, all these things can be released. Once they are released, you know what is the mechanism of sympathetic system on various organ systems of the body, head to toe. Okay, all these things can happen even then if there is a very severe condition which is precipitating this bodily changes which is brought about by the sympathetic system will not be able to compensate. Okay. So this sympathetic system will not be able to compensate in case of our shock. Okay, vasoconstriction, increased heart rate, all these things can be produced by the endogenously produced catecholamines. So increasing the renin-angiotensin axis, sodium water conservation, all these things may no longer be helpful. So what may be the normal mechanism in septic shock? Insult, injury or infection. Injury may lead to hypovolemic shock also. So there can be local inflammatory reactions, release of inflammatory mediators, maybe cytokines, substance P, all these things. Okay, so systemic inflammatory response can be there. Then there can be diffuse endothelial injury, vasodilation and capillary release. So progressive vasodilation, more distribution of the blood flow, and they can lead to hypoperfusion of the organ and multi-organ dysfunction syndrome. Okay. So what is this multi-organ dysfunction syndrome? There will be progressive physiological effects as shock agent. There will be cardiac depression, respiratory system is affected. There will be other vital system, cardiac system and the respiratory system. Then if there is no enough amount of blood passing through the renal system, we can go for renal failure and disseminated intravascular coagulation due to the local thrombotic mechanisms, and this can lead to end organ failure. So how to approach these patients? So history taking may be helpful if the patient is already having some imminent conditions. Okay. So history taking, recent illness, fever, chest pain, abdominal pain, because we are thinking about all types of shock. Recent illness may be helpful in understanding the fever and illness for septic shock, chest pain, or abdominal pain. They both can coordinate for the cardiogenic shock, comorbidities, maybe respiratory conditions like hypertension, congestive heart failure, diabetes, all these things. Maybe medications. Okay, there are some cardiac depressant medications toxin ingestions may be poisoning, all these things. Recent hospitalization and surgery, again, there can be failure of the surgeries and all these conditions. Baseline mental status to find out whether the patient is in sound mind and can answer in the sound mind. In case of this poisoning patient, that will be helpful. So vital signs, we need to be careful. What are the vital signs? Vital symptoms you need to look for. Okay. First, starting with the eyes, pupils are dilated, pinpoint. We already know what are the differential diagnoses for various things. Okay. This is just a summarization of your clinical knowledge here. So CNS mental status, skin color, pallor is there, heart sounds, blood pressure, respiratory rate, all these things. So basic investigations, arterial blood gas investigations, urine output, whether it is good or not, all these things will be helpful in diagnosing the case. So operation of the patient can include the identification of the infectious source, cardiorespiratory monitor, pulse oximeter. Pulse oximeter is a basic simple device at the OPD or any emergency ward. It will give you the oxygen saturation and the pulse. That is very important. Okay. So oxygen supplementation. So you already knowing what is ABCs. Okay. What are the ABCs of the emergency? You want to go out? Your activities second the last stage. I can notice what you are doing. If you want to go out, you can start there. So supplementation of oxygen is very important because A for airway, okay, oxygenation, all these things, correct the track, okay, straighten the head, all these things. Okay, then breathing, you can give the oxygen supply, then circulation. Second, IV line. Okay, you start with ABCs, then go for the GRPS, all these things. Basic things, 4 things you can do at your setup. Then, if you have this setup where you can have this ABC, CBC, chemistries, it will be helpful. Police catheter to know the urine output. So further evaluation, we have if there is any RTS injuries, as we saw in the previous slide, it can be CT, lumbar puncture, wound cultures, because lumbar puncture will help you in understanding the sepsis. Wound cultures, acute abdominal series, okay. For example, maybe post-operative case, okay, abdominal pelvic scan, all these things will be helpful. D-dimer will help you in finding out MI. So there are different types of shocks. As you all mentioned, hypovolemic, septic, and cardiogenic, anaphylactic. So we have the other ones like neurogenic and obstructive. So here we need to understand what are the hemodynamics occurring, hemodynamical changes which will be occurring in case of this shock. Okay. So if it is a hemorrhagic shock, you know that the venous return is less, preload is less. So once preload is less, there can be decreased cardiac output, garbage in, garbage out, something like that. Okay. What you have given the input, once the input is low, less output. Okay, peripheral vascular resistance will be increased and systemic vascular resistance also increased. Anaphylactic shock, there may be increase or decrease, cardiac output will decrease, but peripheral vascular resistance is high. In cardiogenic shock, the myocardial tissue is not functioning well, so the cardiac output is the one which is more affected. So there is decreased cardiac output. Okay, in septic shock, there is decreased preload and there is decreased systemic vascular resistance. You can see in anaphylactic and the septic shock, we have this decreased systemic vascular resistance. Here we have 2 types: septic, hyperdynamic, and hypodynamic. We will be learning about that. Okay, so hypovolemic shock, it can be in the form of hemorrhagic and non-hemorrhagic. Okay, so hemorrhagic, you can see bloody diarrhea, all these things. Then bowel obstruction, pancreatitis, burns, environmental, all these can be non-hemorrhagic type. Hemorrhagic type, we have GI, maybe internal bleeding, maybe due to the post-operative or gastritis or the ER-DBCs, where the person has consumed the binge of alcohol. Okay, all these things may be there. Then there can be AAA, that is abdominal aortic aneurysm. All these things can be seen. Ectopic pregnancy, it can be concealed. You take a scan, regular scan at about 2.5 months, you will not be having but that will help you in finding out whether there is any ectopic pregnancy if the person presents with the pain or not. Postpartum bleeding due to rupture or any other things. Then hypovolemic shock, what are the different ways we will be approaching the case. So ABCs you know. Along with that, we will start with 2 IV cannulas on either side. Okay, large bore. What is this large bore? What is the maximum? 18 gauge needle. Have you heard of it? Okay. So our drip system will come with this 18 gauge needle that will be helpful in fast giving of the salines of the fluids. Okay. To give O negative blood, if you have enough time for cross matching, it's okay. But if you don't have, you can give the O negative. Okay. So control the bleeding if it is visible, if it is internal, suspected. So arrange for the definitive treatment. How will you arrange for the definitive treatment? It will be mostly based on the what conditions we are having there. So hypovolemic shock, how to go about this? Okay, so what will be the total body water required now normally present? 42 liters. So intracellular fluid we have 28 liters. We cannot do anything about this 28. Okay, so we can do something about this extracellular fluid, because among that extracellular fluid we have interstitial and intravascular. So whatever the fluids or the electrolytes or the crystalloids, colloids we will be giving, they will be entering this compartment ECF. Okay, so among this, what is more important for us to maintain the blood pressure? Intravascular fluid. Okay, so we need to administer a drug or a fluid which will increase this intravascular fluid and bring about the normal blood pressure. So once we have this blood pressure at somewhere around normal, it will help the proper tissue perfusion. Once there is proper tissue perfusion, okay, we can get the tissues functioning normally. Okay, so there will not be any chances of end organ failure. Okay, how we can do this? We will learn it now. So we have crystalloids and colloids. Okay, crystalloids can enter both ECF, ICF, that is interstitial fluid, and intravascular also. That means whatever we administer, the 3/4 will be going to the interstitial. Only 1/4 will be available for the vascular amount. So we should go for a preparation which will go into the vascular compartment only, and that fluid will be colloids. Okay. So colloids enter only IVF, intravascular in short term. Okay, 16 hours, then they enter into the ISF. So that much of 16 hours of breathing period you can get. Okay, so you can stabilize the patient with some other injuries or the assault which is done on the body. So intravenous fluids, along with that we can go for the blood transfusion if it is a hemodynamic. By this time, I think that you all been knowing something about the blood transfusion, what are the demerits, what are the chances of the reactions, all these things. Okay, so have you witnessed any blood transfusion in your clinical postings? Yes. So how they start? First they give early injections, they can give the hydrocortisone initially in order to avoid any adverse events, all these things, and how surgeon is kept at place or made to sit to watch this. Okay, so that will be about our blood transfusion. Nowadays we have the better ones in order to increase the oxygen carrying capacity without giving the blood. That will be PAX, red cell transfusion. Okay, so increase the oxygen carrying capacity. Then fresh frozen plasma, where we can give plasmapheresis, where it is given, you need to remember. Okay, try to remember where we are giving this plasmapheresis, where transfusion is given. Any idea? One condition we have discussed is myasthenia gravis, plasmapheresis, succinylcholine. What is the treatment? Fresh frozen plasma. In order to metabolize this successfully. Okay, so till now what we have discussed, I asked. Okay, so the most common one which we have discussed extensively in your practical in the class is suction and about suction and techniques. So then we have this normal lumen serum albumin, okay, that can reduce the edema and increase the plasma volume. Then we can go for this colloidal plasma expanders. Okay, so we told that colloidal plasma expanders are the ones which can be there in the intravascular fluid for longer time, maybe till the plasma half-life of the drug is there, then they will enter the interstitial fluid. Okay, so dextran isolated from beetroot, so it inhibits the chloride formation, that is the RBCs coming together. Then we have hydroxyethyl starch, okay, it is resistant to the hydrolysis and can maintain the blood volume for longer. Polyvinyl pyrimidine, synthetic water soluble hydrophilic polymer. Then hemacine we have polypeptide dissolving electrolyte, and then we have this dextrose. Okay, so the normal saline, ringer lactate, GNS, most of these are crystalloids. Okay, so these are the ones which will be colloids. These will be helpful in hypovolemic shock. So then we have the drugs which can increase the heart rate, all these things. Okay, inotropic agents. So they are important pharmacological agents which can be helpful. Can you name some inotropic agents? The drugs used in congestive heart failure, inotropic agents. Yes. What are the agents here? You can recall them. Okay, epinephrine, norepinephrine, dopamine, dopamine, phenylephrine, vasopressin, and ambrinolone. Okay, so ambrinolone is a milrinone. Ambrinolone they are the phosphodiesterase inhibitors that will be helpful here. So, in which case we will be thinking about this epinephrine? Anaphylactic shock. Okay, so they can act on these receptors. You need to remember. Then what they can do? They can increase the cardiac output and also systemic vascular system. They are not extensively used drugs. They are used for specific purposes. Okay, only in case of emergencies, that is anaphylactic shock, and maybe a person in syncope or a unconscious patient. Okay, so norepinephrine, they can be acting on alpha and beta receptors. They increase the systemic vascular resistance. Dopamine, they can act on both beta and dopamine receptors. They can increase the cardiac output. So dopamine, you need to remember, we have three different doses where they can act. Okay, at low doses, that is about 1 to 30 microgram. So that is the dose we are using here. So dopamine, both beta 1 and beta 2 receptors, they can increase the cardiac output. Vasopressin, they can increase the systemic vascular resistance. Phosphodiesterase inhibitors, they can increase the cardiac output. So nifedipine, remember what is that? Calcium channel blocker. It is a short-acting calcium channel blocker. You need to remember these calcium channel blockers and the nitrodilators. There are nitroprosides and the calcium channel blockers. They have tendency for what? Decreasing the preload or the afterload. Okay. So in the case such as septic shock or cases like cardiogenic shock, these drugs are used carefully when the blood pressure is okay, like that. Okay, that means maybe above 90, 70 or 170 like that. Okay, because they have their own demerits, maybe in the form of coronary street syndrome or hypovolemia. All these things can be caused. So sodium nitroxide, doxycycline, nitroglycerin, all these things can be helpful. Coming to dopamine. What is this dopamine? You might already be knowing something about this dopamine system, where it is involved. Okay, so it is just a brush up here. So endogenous precursor, it can be having multiple dose-related effect. Low dose, predominantly we have inotropic action. Okay, so they enhance the blood flow to the renal. Then moderate inotropic, high we have vasoconstriction. So we will keep it in the dose here only, low and moderate dose. So where these different types of drugs can be used. Phenylephrine, septic and neurogenic shock, norepinephrine, septic shock, epinephrine most commonly in anaphylaxis. Okay. Then dopamine, renal insufficiency and septic shock. Then dopamine, cardiogenic shock, isoprotazma or isoxaprine, we can use it in bradycardia. Then milrinone for cardiogenic shock. So epinephrine or the adrenaline, it is a catecholamine. Okay, it is shown maybe in some of the also you might have seen that adrenaline is given directly in the heart in some emergency conditions. We no longer use those things because it can trigger the arrhythmias. Okay, so because people are more influenced by what they see and just making it a point. Okay, most commonly we give it by intramuscular. Okay, subcutaneous route can be given. Again, there are some disadvantages associated with that. Okay, so better to give it a intramuscular. So it's a drug of choice for anaphylactic reactions. It can be given by endotracheal tube also. So then we have this isoxaprine, synthetic catecholamine. Okay, you know it works on beta receptors. So milrinone is a drug. Milrinone or the phosphodiesterase inhibitors. It is a newer drug which will be helpful in our what? Where it is used? Congestive heart failure. Okay. So it can increase the cardiac output without increasing the heart rate and the myocardial oxygen demand. So if the myocardial oxygen demand is also maintained, that means it can also be used for angina. Okay. So in angina we have decreased supply and increased demand. Okay. So this can be helpful in the angina and CCF also. So it improves the cardiac output and also renal perfusion. So at less amount of energy it can work better. Less amount of oxygen supply it can work better. Norepinephrine, phenylephrine, you already know these drugs. Okay, norepinephrine, what receptors they act. All these things. So coming to the sepsis. So what is this sepsis? We need to have some criteria to tell it is a sepsis. So the criteria is systemic inflammatory response syndrome criteria. Okay, here the temperature is more than 38 or less than. Okay, that's what we are telling. Hypovolemic may be there, hypervolemic may be there. Heart rate more than 90, respiratory rate more than 20. What is the normal respiratory rate? 40 to 18. So here it is more. So you can also see here WBC count what it is doing. So WBC count it is less than 4,000 or above 12,000. Okay, so normal thinking is if our WBC levels are more than 20,000 or 30,000, we are suspecting from leukemias also. But here we have one more condition, it is acute onset, but still there is more leukocyte count. Think of this sepsis. Okay, here the blood pressure can be very low or normal. So you can see here systolic blood pressure can be like less than 90 or mean arterial pressure will be less than 65. Okay, so 3 things MAP, remember, divided by 3, 2 diastolic plus 1 systolic, which will be above 65. So if it is below, you can think of this condition. So toxic shock syndrome, it will be due to the sepsis by Streptococcus pyogenes and Staph aureus. Okay, so here they have fever, other symptoms associated with sepsis. Along with that, they have some features such as very high fever, diffuse rash, leaks formation, and hypotension. So you might have heard about this orthostatic hypotension, which we discussed as the adverse effects of some drugs. It was due to So here is our sepsis, infection, systemic inflammation response syndrome, all these things. It can be due to all these things. It may not progress to sepsis, but these are the precipitating factors, maybe bacteremia, fungemia, parasitemia, viremia, all these things can precipitate our sepsis. So treatment, again, as we started with our hypovolemic shock, we are starting with both two IV cannulas with Y4, absence of limitation, ABCs we are doing. Okay, then we are going for empirics and empirical antibiotic treatment, and which can cover both analogic, gram positive and gram negative. What are those drugs? We can start with piperacillin. Piperacillin is a penicillin group. Tazobactam is a beta-lactamase inhibitor. Okay, so beta-lactamase inhibitor, then tazobactam, ceftriaxone, imipenem. Okay, yes. But what is imipenem? Yes. Stand. What is imipenem? Any idea? See, these are the next group of drugs in the penicillin group, next to penicillin group, which can inhibit the cell wall synthesis. Cell wall synthesis means they are bactericidal. Remember, okay, the drugs which can act on the cell wall are the bactericidal, that is piperacillin, imipenem, and all these things. Okay, so 1 gram intravenously they are given. Additional coverage for pseudomonas, we can go for this gentamicin, it is a aminoglycoside. Then we have cefepime, okay, it is a 4th generation cephalosporin. For MRSA, that is, what is MRSA? Staphylococcus, yes, we can go for vancomycin. Okay, so now in our college we have the next drug under going for Chambers approval for the MRSA. Okay, so we are trying the abacus. It is a newer drug for this MRSA. Hopefully we will do that study. Okay, so intraabdominal or the head and neck anaerobic infection, we can go for this clindamycin and metronidazole. Metronidazole, most cheapest, strong antibiotic. Okay, so last best, second person, red shirt, please stand. Okay, then we can go for this ceftriaxone for serial meningitis, then neutrophilic, cefepime and imipenem. Okay, cefepime again the 4th generation drug. So we already learned something about this. So what is this? Cardiogenic shock. Okay, this side. You should know one who is dosing by body. So both of you. So systolic blood pressure here, normally it should be systolic blood pressure normally, yes, around. Okay. So if it is less than 90, clearance less than 2.2. So pulmonary capillary blood pressure more than 80. All these things are indicative of this cardiogenic shock. So this pressure is increased means there is pulmonary perfusion also. So skin signs, we have good peripheries, tachypnea, hypotension, altered mental status, narrowed pulse pressure, veins and murmurs. So what are the different causes of this cardiogenic shock? We know something about this acute myocardial infarction. In the last class we studied what are the different ways we can deal with this myocardial infarction. Sepsis, myocarditis, myocardial confusion, okay, acute or aortic or mitral stenosis, hypertrophic cardiomyopathy, acute aortic infection. All these conditions can lead to cardiogenic shock. Okay, so there ischemia, loss of 40% of function, then there will be clinical symptoms. So there is decreased cardiac output means there will be lactic acidosis, hypoxia, decreased stroke volume, we can lead to tachycardia and tachycardia, all these things. So what are the different goals here? Supplementation, IV access, fluid replacement. So you already learned in the last class, okay, what are the different? We have the beta anxiety, you can go for the drugs for painkillers, maybe opioid drugs, then we can go for this thrombolysis, tetrakinase, urokinase, all these things. Then inotropic drug if the patient is having hypotension, dopamine, all these things. Then we can go for intervention, that is percutaneous coronary intervention if there is any block there. Then fluids, all these things. So we can go for dopamine, milrinone, norepinephrine, oxygen. Dopamine is confirmed by D-lemma. You can go for this heparin, revascularization, all these things. So pulmonary edema, you can go for this AC inhibitors. First status, prisomide, morphine, all these things. Hypovolemia, we need to think about the fluid replacement. Low output cardiogenic shock, we need to go for this. Systolic blood pressure is more, we can go for this nitroglycerin or the nitrates. If it is less, we cannot think of it. We can start with this very less, we can go for this norepinephrine. If it is moderate, you can think of this dopamine and dopamine. Arrhythmias, you need to keep started antiarrhythmic drugs suitable. Then if it is bradycardia, you can go for the drugs which can prevent that. Okay, so we have different group of